Okay, let's unpack this. You're getting ready for your first aid at work practical course, the one with Paul from Paul Kenny Training.
Right. And you've probably done the online stuff, finished those modules.
Exactly. But now you're thinking about the hands-on assessment, and maybe it feels, well, a bit daunting.
It can definitely feel that way. So think of this as like a helpful chat beforehand.
Yeah, welcome to the deep dive. We're basically trying to make you feel a bit more prepped, a bit more confident for those practical days.
We're taking all that theory you learned online and figuring out how to make it really stick, for when you're actually doing things.
Think of it like a fun study guide, focusing on the doing part.
Highlighting the really key bits from the FAW 5th Ed book, the latest on serious bleeding, those April 2022 EFAW updates.
And specifically, the practical assessment topics you'll likely cover with Paul in 2025.
Our mission, if you like, is to pull out what's absolutely essential so you know the what's and, crucially, the why.
Making those connections, this is your pre-course huddle, basically. Boost that confidence.
It really boils down to translating screen learning into action, right?
Yep.
That's the bridge we want to help you build. Understanding the steps, the logic. That's key for the assessment.
Okay, let's dive straight into day one prep. It all starts with DRABCD. You've seen it online, for sure.
But let's make it feel second nature. First up, that scene survey. Remember, CLAP.
Kinole, control. Look, assess, protect, and prioritize.
Exactly. And the control and look parts are all about your safety first. You can't help if you get hurt.
Makes sense. So, look is scanning for what? Spills, wires, anything dangerous.
Anything at all. Unstable stuff, potential hazards. It's your quick risk assessment before you even get close. That L feeds right into the D for danger in DIBCD. Your safety, always.
Right. Then assess, quickly figuring out what happened. Talk to them if they're awake or witnesses.
Get the gist of the situation. And protect and prioritize. That means gloves on, absolutely essential.
Gloves, yes. Infection control. And if there's more than one person...
Quick decision. Who needs help most urgently? Then you move into the actual DRABCD sequence.
Okay, so danger checked with CLAC. Next is our response. How do we check that?
Use the AVPU scale. Alert, voice, pain, unresponsive.
So are they awake? Do they answer you?
Yeah. If not, try a gentle shake on the shoulders, ask loudly, "Are you all right?" See if that gets a response.
And if nothing...
Then it's A for airway. Head tilt, chin lift, one hand on the forehead, tilt back gently.
Fingertips under the chin to lift it up.
Correct. That simple move often lifts the tongue away from the back of the throat, a really common blockage in unconscious people.
Could it be blocked by other things, like vomit?
It could, yeah, or a foreign object. So opening and checking that airway is fundamental before you check for breathing.
Right. Look, listen, and feel. For how long?
No more than 10 seconds. And you're looking, listening, feeling for normal breathing?
Normal being the key word there. What about those weird gasps you sometimes hear about?
Agonal gasps. Yeah, the Resuscitation Council UK is clear on this. Slow, infrequent, noisy gasps right after cardiac arrest.
Ew.
They are not normal breathing.
So if you see that, or you're just not sure?
Assume they're not breathing normally. Prepare for CPR.
Okay. And if they are breathing normally but still unresponsive...
Then you do a secondary survey, check for injuries, and if it's safe, recovery position, call for help, obviously, and keep checking that breathing.
Got it. Which brings us to C for circulation. In DRABCD, this is mainly about compressions if they're not breathing, right? We'll cover bleeding later.
Exactly. And D is defibrillation. If there's an AED nearby, get it switched on, follow the prompts. It works alongside CPR.
Okay, let's talk CPR and AED in more detail then. Adult CPR hand position.
Heel of one hand, center of the chest. Other hand on top, interlock fingers.
Shoulders directly over hands, arms straight.
Yep, and push down hard and fast. Depth is 5 to 6 centimeters. Think. Height of a credit card on its edge.
And the rate.
100 to 120 compressions per minute. That's the rhythm, like staying alive. 30 compressions, then 2 rescue breaths.
Needs to be on a hard surface, too.
Absolutely. Firm, flat surface. Otherwise, the compressions aren't effective.
What if you can't or don't want to do the breaths?
Compression-only CPR is definitely recommended then. Keep those compressions going at the same rate and depth. Super important.
Is it different for drowning? I think lifeguards do something first.
Good point. Yes. For drowning, the guidance is 5 initial rescue breaths before starting compressions, because the main issue there is lack of oxygen.
Makes sense. What about kids and babies?
Key differences. For infants, you stimulate them differently, maybe tickle their feet. Still do the 5 initial breaths for drowning in both kids and infants.
And compression.
Adjusted. about 1/3 the depth of their chest, for both children and infants. And AEDs, generally not for infants under 1 year old.
Right. Okay, so the AED arrives. What's the drill?
If someone else is there, they carry on CPR while you get the AED ready. Switch it on, follow the voice prompts. Pad placement is key.
There are pictures on the pads, usually.
Yes. Check quickly for pacemakers. Piercings, place the pads away from those. Any medication patches, take them off. Wipe the chest dry if it's wet.
And the big safety call?
Stand clear. Shout it loud when it's analyzing or shocking. Everyone needs to be hands off.
After the shock. Or if it says no shock needed.
Immediately back to CPR. Follow the AED's prompts. Keep going until professional help takes over, the person wakes up and breathes normally, or you physically can't continue. The AED doesn't replace CPR, they work together. CPR keeps blood moving, AED tries to reset the heart's rhythm.
Okay, good clarification. Next up, the recovery position. For someone unresponsive but breathing normally.
Yeah, really vital skill. Keeps the airway open, helps breathing, lets fluids drain out.
How do you do it? Walk us through it.
Okay. Kneel beside them, take the arm nearest you, put it out at a right angle, elbow bent.
Got it. Arm at a right angle.
Then bring their other arm across their chest, back of their hand against their cheek, the one nearest you.
Hand on cheek. Okay.
Now with your free hand, grab their far leg, just above the knee, pull it up so the foot's flat on the floor.
Knee bent, foot flat.
Right. Now use that bent knee to help roll them towards you, onto their side. Keep their hand supporting their head under the cheek.
Roll them over gently.
Exactly. Then adjust that top leg, the bent one, so the hip and knee are at right angles. Makes them stable.
Stops them rolling back.
And finally, just double check the airway. Tilt the head back slightly if needed. Ensure it's clear.
Anything else to watch out for?
Definitely check for injuries before you roll them. If they're going to be there a while, try to turn them on to the other side every 30 minutes or so if injuries allow.
What about pregnant women?
Left side is preferred, if possible. Helps blood flow back to the heart.
And spinal injuries. Big no-no for recovery position.
Generally, yes. Unless you absolutely cannot manage their airway any other way. Otherwise, keep them still. Minimize movement.
And keep checking their breathing the whole time.
Constantly. Their condition can change fast. You need to be ready to go back to CPR if breathing stops.
Makes sense. Okay, let's focus on breathing issues now, specifically choking. Mild versus severe.
Big difference. Mild obstruction, they can usually still cough, maybe speak a bit, might look flushed.
What do you do then?
Encourage them. Keep coughing. That's usually the best way to clear it.
And severe.
That's when they can't cough effectively, or it's silent. Can't speak, can't breathe properly. Obvious distress. Maybe turning blue around the lips, cyanosis. That's urgent.
Okay, severe choking. Adult or child, what's the sequence?
Up to 5 back blows first. Stand beside and slightly behind them. Support their chest. Lean them forward.
So gravity helps.
Exactly. Then 5 firm blows between the shoulder blades with the heel of your hand.
And if that doesn't work?
Up to 5 abdominal thrusts. Stand behind them, arms around their upper abdomen. Make a fist. Place it between belly button and ribs.
Some side in?
Yep. Grasp that fist with your other hand. Pull sharply inwards and upwards, up to 5 times.
And keep repeating. Back blows, abdominal thrusts.
Cycles of 5 and 5. Call emergency services early on, especially if it's not clearing. Use speakerphone if you're alone.
What if they become unresponsive?
Stop the back blows and thrusts immediately. Lower them carefully to the ground. Start CPR. Check them out for the obstruction periodically during CPR.
And infants, no abdominal thrusts, right?
Too risky. For infants, it's up to 5 back blows, same positioning as adult, but maybe over your lap, and then up to 5 chest thrusts. Use 2 fingers in the center of the chest, just below the nipple line, like CPR compressions, but sharper.
Got it. Back blows and chest thrusts for infants. Okay, moving on to seizures. Epilepsy is one cause, but there are others.
And different types, too. Partial seizures might just be brief confusion, staring, odd sensations, maybe twitching.
Not always the dramatic falling and shaking.
No, that's more typical of a generalized seizure, like a tonic-clonic seizure. Those often have stages.
Stages? Like what?
Some people get an aura, first a warning sign like a smell or feeling. Then the tonic phase muscles go rigid. They might fall, maybe turn blue briefly.
And the shaking.
That's the clonic phase, jerking limbs. They might lose bladder control. They're unconscious. Then comes the recovery phase, waking up slowly, often confused, tired, headachy.
Okay, so someone's having a tonic-clonic seizure. What's the first aid?
Safety first. Clear space around them. Remove hard or sharp objects. Don't restrain them. Don't put anything in their mouth.
Let the seizure happen.
Pretty much. Try to note the time it started. Maybe loosen tight neckwear. Cushion their head if you can, but don't force anything.
And after the jerking stops?
Check airway and breathing immediately. If breathing normally, recovery position. Stay with them, offer reassurance. They might embarrassed or confused.
When do you call for help?
Call 999 or emergency services if it's their first ever seizure. If it lasts longer than 5 minutes, check local guidelines on duration, or if they have several seizures without fully recovering in between, or if they're injured. Being able to describe what you saw, the different phases, is helpful for your assessment too. Shows you recognize the signs.
Good tip. Okay, external bleeding, different types.
Yeah, the manual breaks it down. Arterial bright red, spurting, that's serious, life-threatening. Venous darker red, flowing steadily, can also be life-threatening if it's heavy. Capillary oozing, usually minor cuts, grazes.
Right. First up for any bleeding.
Gloves, always gloves. Then get the person to sit or lie down.
Prevents fainting. Then look at the wound.
Yep, examine it. Don't pull out anything stuck in there, though. Main treatment is direct pressure. Use a sterile dressing, ideally, or a clean, non-fluffy pad.
Just press down hard.
Firm, direct pressure right on the bleeding point. If it's a limb and not broken, elevating it above the heart can help too.
What if the blood soaks through the first pad?
Don't remove it. Put a second one on top. Keep pressing.
And if that one soaks through?
Okay, then you take both off and start again with a fresh pad, applying direct pressure. Maybe you didn't have pressure in quite the right spot initially.
Can bandage it up.
Once bleeding is controlled. Yeah. Secure the dressing with a bandage, firmly, but check circulation, press a nail bed, see if the color returns quickly. Make sure it's not too tight.
Now, there's new info on life-threatening bleeding, right? Tourniquets and packing.
Yeah, the First Aid Quality Partnership, updated guidance. Direct pressure is still number one. But for really severe, catastrophic limb bleeding, that direct pressure isn't controlling.
Like spurting blood, pooling blood.
Exactly. Then tourniquets or wound packing might be needed. You can improvise a tourniquet with a triangular bandage and something to twist it tight.
Like a stick?
Yeah, or use a manufactured one. Wound packing means stuffing clean material, like bandages or even clothing, tightly into a deep wound. There are also special hemostatic dressings that help clotting.
But you need training for these.
Definitely. The HSE says employers should assess if these are needed based on workplace risks and provide proper training. They're not for everyday cuts.
Okay, what about embedded objects, stuff stuck in the wound?
Leave it in. Removing it could make bleeding much worse. Apply pressure on either side of the object, build padding around it to support it.
And amputation, horrible thought, but what do you do?
Control the bleeding from the stump first. Treat for shock. Call emergency services immediately. Dress the stump wound. Then care for the amputated part. Put it in a clean plastic bag, seal it. Put that bag on ice or in cold water. Don't let the part freeze or get waterlogged. Label it with the person's details and the time it goes with them to hospital.
Wow. Okay. That leads into shock, hypovolemic shock.
Caused by blood loss.
Mostly, yeah. Severe bleeding, internal or external, but also severe vomiting, diarrhea, major burns, even extreme sweating can cause fluid loss leading to shock. The body doesn't have enough fluid volume circulating.
What does it look like?
Pale, grayish, or blue skin. Cold and clammy to touch. Weak, rapid pulse. Fast, shallow breathing. Maybe nausea. If it's from bleeding, you might see the wound.
Treat that.
Treat the cause first, like stopping bleeding. Lay them flat, raise their legs above heart level unless the legs are injured, loosen tight clothes, keep them warm, monitor airway and breathing constantly.
Anything to drink?
No, absolutely nothing to eat or drink. Call emergency services immediately.
Got it. Last section for day one prep. Bones and joints. Fractures, dislocations, sprains, strains. How do you tell the difference? It can be tricky without an x-ray, but there are clues. Fractures and dislocations usually mean significant pain, tenderness, bruising, swelling, loss of movement. You might see deformity. The limb looks wrong.
Any sounds.
With fractures, sometimes a grating sound or feeling crepitus. Dislocations might have an unnatural look at the joint. Nausea from pain or shock is common too.
Okay. And sprains.
That's ligament damage at a joint. So pain, swelling, bruising, difficulty moving the joint.
Sprains.
Muscle or tendon injury, pain, maybe muscle weakness, localized swelling or bruising, sometimes cramps.
General treatment for suspected fractures or dislocations.
Gloves on, control any bleeding first. Then the main thing is immobilization. Support the limb in the most comfortable position for them. Don't try to force it straight if it's deformed. Call emergency services.
What about slings? You need to know how to do one.
Yes, applying a support sling using a triangular bandage is a common practical skill. The manual shows how. base parallel to the body. Bring the lower end up to the shoulder. Tie a reef knot in the hollow above the collarbone. Secure the elbow point.
Treat dislocations like fractures.
Generally, yes. Immobilize and get medical help. Don't try to pop it back in yourself.
And for sprains and strains, the simpler stuff.
I see. Rest the injured part. Ice wrapped in a cloth. Maybe 20 minutes helps with swelling and bruising. Compression, a gentle bandage. Elevation, raise the limb if possible.
Phew. That's quite a bit for day one. But you see the connections, right? Airway, breathing, circulation, they keep coming up.
Definitely. Okay, let's gear up for day 2 prep. Starting with head injuries. Can be scary.
Very. The manual talks about concussion, cerebral compression, skull fracture. But as first aiders, we're not diagnosing. We're spotting signs and acting.
So concussion signs. Maybe brief blackout, dizziness, headache, memory loss, blurred vision.
Could be. Cerebral compression is more serious. Pressure building inside the skull. Look for worsening headache, drowsiness getting worse, maybe one pupil bigger than the other.
Oh, wow.
Slow, strong pulse, maybe weakness down one side, noisy breathing. It develops after the initial injury sometimes. Skull fracture, you might see a wound. Deformity. Bruising around eyes or ears. Fluid leaking.
Exactly. Clear or bloody fluid from ears or nose could be cerebrospinal fluid, CSF. Very serious sign.
General first aid for any major head injury then.
Control any bleeding or CSF leakage gently with a clean pad. Call emergency services immediately. Get them comfortable, flat usually, but head and shoulders slightly raised if possible. Helps reduce pressure. Monitor airway and breathing constantly.
And if you suspect a skull fracture and maybe a neck injury...
Don't turn the head. Keep everything aligned.
Which leads right into spinal injuries.
Causes. Car crashes, falls from height, diving accidents, sports impacts. Anything causing significant force to the spine.
Signs. Pain in the neck or back is a big one.
Yeah. Or an odd head-body position, can't move limbs, or weakness dingling, loss of bladder bowel control, signs of shock.
Okay. Conscious person suspected spinal. What do you do?
Call 999 straight away. Keep them completely still. Immobilize the head and neck. Gently hold their head with your hands on either side. Keep it in line. Tell them not to move. Don't ask questions needing nods or shakes. Keep them warm.
And if they're unconscious?
Check breathing first. If not breathing, start CPR, being mindful of movement. If they're breathing, don't move them unless absolutely necessary immediate danger or you can't keep their airway clear.
How do you manage the airway then?
Try to maintain that head tilt and lift carefully, keeping the head and spine aligned. Call emergency services. Keep warm. Monitor. If you have to move them for the airway and you're alone, use the recovery position, but very carefully, maintaining alignment if you have help.
One person focuses solely on stabilizing the head and neck, while others carefully log roll the body as one unit. Takes practice and coordination.
Definitely. Okay, chest injuries. Rib fractures first. Painful.
Very. Especially when breathing, coughing, moving. Might hear a grating sound. Treatment.
Make them comfortable. Sitting often helps splint it. Needs medical assessment.
More serious. Penetrating chest wound. Sucking chest wound.
Yeah, object goes through the chest wall, air gets sucked in, see an open wound, hear a sucking sound maybe, difficulty breathing, bubbling blood, coughing blood.
Scary. What's the first aid?
Call 999. Gloves on. Don't remove the object if it's still there. Position. Half sitting often helps breathing or maybe lying on the injured side.
Do you seal the wound? I thought you used to.
Current advice is generally not to apply an airtight seal. Can trap air inside, cause tension pneumothorax, leave it open, or if you must cover it for bleeding, use a non-occlusive dressing. Control bleeding around the wound edges gently. Treat for shock. Monitor breathing.
Okay. Let's switch to major illnesses. Anaphylaxis. Severe allergic reaction.
Very rapid whole-body reaction. Triggers. Stings, nuts, shellfish, some medicines.
Signs. Swelling is a big one. Face, tongue, throat.
Yes, leading to breathing problems. Red, blotchy, itchy skin all over. Nausea. Feeling really anxious.
Treatment. Use their own auto-injector, like an EpiPen.
Immediately. If they have one and can use it or you can help, then call 999 straight away. Even if they feel better, the reaction can come back.
Seek them down.
Yes, if conscious. Helps breathing. Remove the trigger is safe, like a stinger. Monitor airway, breathing. Be ready for CPR. They must go to hospital.
Try to tech. Blocked blood supply to the heart muscle.
Classic sign is chest pain, tightness, pressure, heaviness. Can be mild or severe. Often radiates to left arm, neck, jaw, back.
Other signs. Dizziness, shortness of breath.
Nausea, vomiting, cold sweat. Might clutch their chest.
What do you do?
Call 999 immediately. Sit them down comfortably, often leaning back. Knees bent helps ease strain. Loosen tight clothes. Keep warm. Monitor breathing.
Aspirin.
Yes, if available. and they're not allergic, and it's safe for them. Get them to chew one adult tablet, 150, 300 milligram. Helps thin the blood. Be ready for CPR if they collapse.
How is angina different?
Similar chest pain symptoms, but angina is usually brought on by exertion or stress and goes away with rest, typically in under 15 minutes. It's temporary lack of oxygen to the heart.
First,
Ask if they've had it before. If yes, help them rest and use their own GTN spray if they have it. If it's a first attack or the pain doesn't ease quickly with rest and meds, treat it as a heart attack, call 999.
got it. Stroke. Acting fast is key here.
Absolutely fast. Face drooping, arms, they raise both, speech slurred. Time, call 999 immediately if you see any of these.
Other signs, too. Sudden balance issues, vision problems, severe headache.
Can be. Main thing is, call 999 straight away. Time is critical for stroke treatment.
First aid while waiting.
If conscious, comfortable position, head and shoulders slightly raised often helps. If unconscious but breathing, recovery position ideally affected side down. Loosen clothes, clear airway if needed, monitor breathing, be ready for CPR.
Okay. Asthma attack. Airways narrow, inflamed. Triggers like dust, pollen, fur.
Yeah. Signs are difficulty breathing, gasping, wheezing sound, chest tightness, coughing. Severe cases might show blue lips and cyanosis. Can become unconscious.
So the first aid.
Help them sit down, usually leaning forward. Assist them with their own reliever inhaler, usually blue, preferably with a spacer if they have one. Reassure them.
When to call 999.
If the attack is severe, doesn't improve quickly with the inhaler, if it's their first attack, or if you're worried at all, be ready for CPR. Knowing how to help with an inhaler is useful.
Right. Diabetic emergency. Specifically, low blood sugar hypoglycemia or a hypo...
Happens when blood glucose drops too low, maybe too much insulin, missed meal, unexpected exercise.
Signs can come on fast.
Yep. Blurred vision, hunger, tiredness, poor concentration, fast pulse, headache, tingling lips, fingers, maybe acting odd, irritable, confused, skin often pale, cold, sweaty, breathing usually normal or shallow.
What do you give them if they're conscious?
Sugar, fast-acting glucose, about 15, 20 grams. Glucose tablets are ideal. Or jelly babies, fruit juice, non-diet fizzy drink.
Don't wait.
Wait 10, 15 minutes. If they improve, give them something more substantial, longer-acting carbohydrate, like a sandwich or biscuit.
And if no improvement, where they become unconscious?
Call 999 immediately. If unconscious, don't give food, drink. Recovery position if breathing. Be ready for CPR if they stop breathing.
Okay, and finally, that new topic for 2025. Tourniquets or wraps. We touched on tourniquets for severe limb bleeding.
Right, when direct pressure just isn't enough for life-threatening bleeding from an arm or leg.
You mentioned manufactured ones, like the Slishman pressure wrap.
And that's one example, yeah. It's designed as a multi-use pressure device. Often comes in a case, uses hooks and straps to apply circumferential pressure. Can be adjusted, has a time indicator.
You said multi-use, not just bleeding.
Manufacturers suggest uses like splinting, compression for sprains, even head injury sometimes.
Yeah.
But its main focus in this context is severe hemorrhage control.
And the key takeaway is training.
Absolutely critical. You need proper training to use tourniquets or hemostatic dressing safely and effectively. Depending on your workplace risk assessment, this might now be part of your practical course with Paul Kenny training. It's for those extreme situations only.
So that covers the main practical topics for day 2. Bills on day 1 covers more specific injuries and illnesses.
Exactly. From head and spinal injuries to medical issues like anaphylaxis, heart attacks, strokes. It's a lot, but hopefully breaking it down like this helps.
Yeah, seeing those connections like airway management popping up everywhere, understanding the why behind the actions.
That understanding really helps solidify the knowledge, doesn't it? Makes it less about just memorizing steps.
Definitely. So we really hope you'll look back at your online notes now with maybe some fresh perspective after this chat.
Hopefully those little aha moments click and you feel more ready for the hands-on stuff.
Which leads to our final thought for you.
Yeah. Take a moment now. Think about your specific environment, your workplace, maybe home, out and about. What kind of first aid situations might you realistically encounter there?
How would you apply what we've talked about in those scenarios?
Because the practical course is where you'll build on this foundation, practice the skills, and gain that real confidence to step up and act when someone needs help.
Absolutely. Well, thanks for joining us on this deep dive. We really wish you the best of luck on your First Aid at Work practical course with Paul Kenny Training.
Good luck. You've got this.